Welcome back students. Now in this session of gynecological oncology, we will be discussing about a pre-malignant condition and a malignant condition. The pre-malignant condition in this video we will be discussing is a cervical intraepithelial neoplasia followed by cervical cancer, which is a malignant condition. So now let's start from the basics. Okay guys, what exactly is this transformation zone and how it is important in the topic of CIN as well as cervical cancer? See, this transformation zone, in the name itself, it's very clear that there is some transformation is happening. So what is that thing which is getting transformed? Please concentrate that your endocervix or the cervical, in the cervical canal, that endocervical part is lined by the columnar epithelium. Okay. And the ectocervix, which is more toward the vagina. The ectocervix is lined by the squamous epithelium. Okay, so ectocervix is lined by squamous epithelium and endocervix is lined by columnar epithelium. So the junction where the columnar epithelium being converted into a squamous epithelium, that junction, this junction is known as a squamocolumnar junction or transformation zone. So there is a transformation of the columnar epithelium into squamous epithelium. So what kind of change is this, guys? It's a metaplastic change. It's a metaplastic change which is happening in the transformation zone. So this is the first important point. And this transformation zone, it's a dynamic point. What does I mean by dynamic point? It usually moves inwards and it moves outward. Please concentrate. This transformation zone will be taken in with the age. So with the increase in age, this transformation zone will be sucked in into the cervix, more towards the cervix, into the cervix. But during pregnancy, during puberty, and with the usage of oral contraceptive agents, this transformation zone is more likely to be exposed outward. Okay, so it moves outward with the pregnancy, puberty, and with the OCP drug usage. Now, where exactly this transformation zone is located? Theoretically, we know it is the junction between the endocervix and ectocervix. So, where exactly the location? See, this is a very important MCQ. It is located 1.7 to 2.3 centimeters from the external os. Okay, from the external os, it is located away 2.3 centimeters. This is a important MCQ which you should know for your exam. So what is the importance of this transformation zone? The importance is such that this is the site for the dysplastic changes to happen and neoplastic changes to happen. So this transformation zone is the most common site for a pre-malignant condition, that is cervical intraepithelial neoplasia, and also for the malignant condition, which is cervical cancer. So both cervical cancer and CIN are more likely to be arise from the transformation zone or squamocolumnar junction. Now what you should know from this image? Guys, please concentrate that in this image you are having a red color area. See, this red color area which you are seeing here is the endocervix. Surrounding the endocervix, this pale white color area, the pale white color area which you are seeing is this is the white color area. That's what is the squamocolumnar junction or transformation zone. Surrounding the white color region, you are having a pink color area. So this pink color area is your ectocervix. Guys, please concentrate that the pinkish region is the ectocervix and the endocervix is more reddish in color and the transformation zone is a pale white in color. Now what else you can identify from this image? Guys, usually during pervaginal examination, you are not supposed to see the endocervix. Okay, usually endocervix is more inside, no? So you can't see endocervix, but in this image you can see that the endocervix is a bit towards outside. So this condition is known as ectropion. Okay, ectropion. So what is meant by ectropion, guys? Ectropion means the endocervix is getting exposed to the outside. So this ectropion is not a dangerous condition. This will be happening even during the pregnancy. Okay, that's not a big thing. See, after saying important points about the transformation zone, let's talk about the cervical intraepithelial neoplasia. Cervical intraepithelial neoplasia is a pre-malignant condition with the dysplastic changes happening in the squamocolumnar junction or transformation zone. See, according to the dysplastic changes, there is a classification of this CIN into CIN1, CIN2, CIN3 and carcinoma in situ. The important point I want you to know here is, see, there are two classifications. That is the CIN classification and Bethesda classification. See, they are one and the same. CIN1, according to Bethesda classification, is LCIL. Okay, even if you don't understand, don't worry. All the concept will be clear. See, LCIL means what? Low squamous intraepithelial lesion. Okay, or low grade squamous intraepithelial lesion. And CIN2, CIN3 and carcinoma in situ, according to Bethesda classification, they are regarded as high grade lesions. First of all, what are the characteristics of this CIN1, CIN2, CIN3 carcinoma in situ, or what are the characteristics of this LCIL and HCIL? They are one and the same. Please concentrate. If I am talking about CIN1, the dysplastic cells are present in the lower 1/3 of the epithelial lining of the cervix. Okay, they are only located to the lower 1/3. Now, if I am coming to CIN2, there is a moderate dysplasia or a bit more dysplasia. Now, the dysplastic cells are seen in lower 2/3. CIN1 is lower 1/3. CIN2 is lower 2/3 of the epithelial lining of the cervix is getting affected with the dysplastic cells. Now, if I am talking about CIN3, the dysplastic cells are seen more than 2/3. More than 2/3 of the epithelial lining of the cervix have undergone the dysplastic changes. Okay. Now, last thing is carcinoma in situ. It is still in. Okay. What does I mean by in? You will get to know. Don't worry. Carcinoma in situ means the dysplastic cells are seen in the full thickness of the epithelial lining, but the basement membrane is still intact. Guys, please concentrate. In CIN1, it's a very mild dysplasia, only lower 1/3 of the cervical lining is affected. In CIN2, moderate dysplasia, not more than 2/3 of the cervical lining is affected with the dysplastic cells. In CIN3, more than 2/3 of the cervical lining is affected, and with the carcinoma in situ, the total length of the cervical lining is affected with the dysplastic changes. But keep that point in mind. The basement membrane is still intact. Okay, there is no breach in the basement membrane. Once if there is a breach, you should call it as a cancer. Why? Because these dysplastic cells, now they will undergo metastasis. Now it's a perfect neoplasia. Okay, now the same thing, CIN1, CIN2, CIN3, we have seen carcinoma in situ, and their characteristics we have seen. Now the same characteristics will be there even for the LCIL and HCIL. What does it mean by LCIL according to Bethesda classification? According to Bethesda classification, LCIL means the dysplastic changes are localized or limited to lower 1/3 of the epithelial lining of the cervix. And HCIL means HCIL includes CIN2, CIN3 and carcinoma in situ. To make things more clear, let me show you an image. Guys, this is something normal. Okay, here this one is something normal. These are the normal cervical epithelial cells, and these are the basal epithelial cells of the cervical lining, and this is the basement membrane. This is the basement membrane which I am showing you here. Please concentrate in CIN1. See, the basal epithelial cells are being affected. How much? Lower 1/3 only. Now in CIN2, the dysplastic cells are getting more increased, that is 2/3. Now in CIN3, more than 2/3 is getting affected. But if I am talking about carcinoma in situ, see, in carcinoma in situ, the whole thickness the whole thickness of the cervical epithelial lining is affected with the dysplastic changes, but basement membrane is still intact. It is still intact. But please concentrate in carcinoma, like in the next image. If there is a breach in the basement membrane, once the basement membrane is breached or broken, now these dysplastic cells are now they are coming out. So now this stage is a perfect carcinoma. This is invasive carcinoma, or the cervical cancer is now getting started. So till here I can say it's a pre-malignant. Okay, there is no metastasis, but from here there is a breach in the basement membrane. Now cancer is spreading. Okay. Now in this image you can also get some more additional information. What is that? So you can ask me why there is this dysplastic changes. Why there are these kind of abnormal changes happening in the squamocolumnar junction. The reason for this changes is because of the infection with the HPV. See, this HPV, human papillomavirus, is going to affect your basal epithelial cells. Okay, this is the important MCQ. The basal epithelial cells in the cervical lining are being getting affected with the HPV, and that HPV will lead to dysplastic changes. Okay, let's continue. Guys, from this slide, what I want you to know. See, it's very clear. CIN1, CIN2 and CIN3 are there here. According to CIN classification, CIN1, CIN2, CIN3. But according to Bethesda classification, the same CIN1 should be considered as L-cell. But CIN2, a CIN3 should be considered as H-cell according to Bethesda classification. This is what I want you to know. Following this, let's see what are the predisposing factors. Why there are these kind of dysplastic changes happening. I have already said you that the most important stimulant for the dysplastic changes is the HPV infection. Okay, in 99.7% of the cases that this HPV is the main etiological agent causing these dysplastic changes. Now, if a female is having early intercourse before 16 years of age. Now, before 16 years means she is more in this is the time of her puberty. We all know that during puberty the transformation zone is more towards the outside. So transformation zone more towards the outside, more chances of getting infection with the HPV. Or promiscuity. Promiscuity means having multiple sexual partners. Okay. How this can lead to dysplastic changes? If the female is having multiple sexual partners, means she might get a sexually transmitted diseases. She is at a more risk of getting sexually transmitted diseases. HPV infection is a sexually transmitted disease. So if she gets this HPV, there will be dysplastic changes. Or multiparity. Okay. So if she is a multiparous woman, if she is giving more and more vaginal deliveries, such vaginal deliveries will bring the transformation zone more towards the outside, more towards the external environment. So if the transformation zone is exposed more towards outside, it have more risks of developing the dysplastic changes. And poor socioeconomic status. Poor socioeconomic status means poor hygiene. Or poor socioeconomic status, maybe she is a commercial sexual worker. So because of the poor hygiene, she is at a risk of getting this HPV infection. Okay, poor hygiene. She is not maintaining her personal hygiene, so that she might get easy infections. So easy infections can also predispose to the CIN. And smokers, this is very, very important, that smoking is a risk factor for CIN. Guys, one important point I want to clear here. See, all these risk factors what I am discussing here, they are risk factors both for CIN as well as cervical cancer. They are the risk factors for both the conditions. If you have CIN, there is a chance that this CIN can be converted into cervical cancer. CIN is pre-malignant, cervical cancer is malignant. Keep that point in mind. So smokers are at a risk of getting CIN as well as cervical cancer. If I am talking about cervical cancer, there are two types of cervical cancer. Squamous cell carcinoma of cervix, adenocarcinoma of cervix. See, smokers, yes, smokers are at a risk of getting squamous cell cancer of the cervix. Okay. Now, immunocompromised individuals, like those individuals who are having HIV, they are at a risk of getting this human papillomavirus and CAN. OCP use, okay, so long term OCP use more than 5 years to 8 years or more than 8 years will cause dysplastic changes. Like using these drugs will keep you at a risk of getting this dysplastic changes. That's what I mean. So OCP usage will cause, for long time use, will keep you at a risk of developing adenocarcinoma of cervix. Guys, smokers for squamous cell carcinoma and OCP usage for adenocarcinoma of cervix. And in utero exposure to diethylstilbestrol. See, a female is there and whenever she is pregnant, she is taking this drug which is the diethylstilbestrol. Now, this diethylstilbestrol will cause anomalies in the developing fetus. If the developing baby is a female, just imagine that the developing baby is a female. Inside the uterus, there is a female child. And the mother is taking this diethylstilbestrol. This diethylstilbestrol is going to act on the reproductive organs and cause anomalies in the reproductive organs. So just imagine that one such anomaly is leading to the transformation zone more towards the outside. So there are the congenital anomalies. That congenital anomalies are kicking this transformation zone more towards the outside. If the transformation zone is more exposed towards the outside, more risk of the dysplastic changes. Please keep that point in mind. And postpartum and puerperal sepsis. Postpartum, what happens, guys? If the female is having a vaginal delivery, imagine. So when the vaginal delivery happens, the baby is going to come out of the cervix. So when the baby is passing through the cervix, it is like bringing this transformation zone more towards the outside. See, it is taking out all the cervical lining. First of all, the thing is it's removing all the cervical lining and the baby is coming out. While the baby is coming out, it is bringing the transformation zone more towards the outside and the total cervical lining is lost. Now this whole cervical lining should be replaced. So now there is so much of mitotic activity postpartum. Okay, there is so much of mitotic activity postpartum and the transformation zone is more towards outside. So now this transformation zone is at a risk of getting infections. So if there is an infection to this transformation zone, there are dysplastic changes that can happen. Okay, there is a chance that dysplastic changes can happen in the postpartum change if she is having a vaginal delivery. Okay, so these are all the risk factors both for CAN as well as cervical cancer. Now, let's see some important points about the human papillomavirus. We have seen that 99.7% of the cases that the HPV is the most common etiological agent. So, it's the most common etiological factor associated with the CIN as well as cervical cancer. So, there are many strains of HPV. So, please concentrate that the HPV 16 is the most common, but HPV 18 is the most specific HPV that's causing the cervical cancer. If someone asks you what is that HPV strains which are associated with cervical cancer, see, with cervical cancer there are two HPV, 16 and 18. 16 is the most common human papillomavirus which is causing the cervical cancer, but 18 is the most specific and most malignant HPV. Okay, most malignant as well as most specific causing cervical cancer is HPV 18. Most common is 16. But there are also other strains of HPV which are at high risk. Like, they are high risk HPV which can cause a cervical cancer. But from your pathobasics, please remember that HPV 6 and HPV 11. HPV 6 and HPV 11, they are associated with what, guys? They are associated with the condyloma acuminata, that is the genital warts. 6-11 causes genital warts, condyloma acuminata. 16-18 causes cervical cancer. 16 is the most common, 18 is most malignant and most specific. After seeing that, let's see. We have already discussed that HPV 16 and HPV 18, they will cause cervical cancer. Okay, we have already discussed that the cervical cancer is of two types, squamous cell carcinoma, adenocarcinoma. See, 16 is associated with the squamous cell carcinoma of the cervix and 18 is associated with the adenocarcinoma of the cervix. Okay, well and good. Now, what is the most common age group for the CIN infection? CIN infection, it's a 20 to 35 years of age, or usually 20 to 30 years of age, very young age. Okay, so what is the most common age group for these dysplastic changes to happen is the 20 to 35 or 20 to 30, whatever. But what about the cervical cancer? See, you can see cervical cancer at two peaks. What does I mean by there are two time periods in a female's life where she is at a more risk or more likely to develop the cervical cancer. So what is that time period? The first peak is seen at 35 to 40 years and the second peak is seen around 55 to 60 years or sometimes almost 60 to 70 years also. Okay, the second peak is seen with the 55 to 60 years or sometimes they can say 65 years. What I want to put into your mind is the bimodal distribution. So they can ask you in the exam that which cancer shows a bimodal age distribution, cervical cancer. First peak in the 35 to 40 years and second peak in the 60 years of age or 65 years of age. But important point here, please concentrate that this HPV, it infects which cells? It infects the basal epithelial cells and leads to dysplastic changes. So this dysplastic changes, if you are seeing under the microscope, that dysplastic changes are known as coilocytes. So what exactly are these coilocytes, guys? Coilocytes are the cervical epithelial cells, are the cells in the transformation zone which have undergone the dysplastic changes. Okay, so coilocytes. Now after seeing this, let's see some more important points about this HPV infection. See, this human papillomavirus, it have certain proteins like L1 and L2. These proteins are helping in the adherence to the cervical epithelial cell. See, this is a cervical epithelial cell which is present in the transformation zone. Now, this is the HPV. See, this HPV uses two proteins L1 and L2 for the adherence. Now, what are the viral proteins helping in the replication? See, E1 and E2, these are the viral proteins which helps in the replication of virus inside the cervical epithelial cells. So, E1 and E2 are helping in the replication. Now, what are the viral proteins which are helping in the malignant transformation? See, it is the E6 and E7 which are proteins which are helping for the malignant transformation. What does I mean by, see, E6, this protein, what it will do? See, E6 protein inhibits the P53 gene in the epithelial cells. So, usually P53 is a guardian angel of the cell. P53 don't let a normal cell to convert into a cancer cell. But whenever P53 gene is inhibited in the cervical epithelial cells, what do you expect? Now the cells will go crazy and they will be converted into cancer, neoplastic cells. And usually RB gene, retinoblastoma gene, is also an retinoblastoma gene is also anti-cancer gene. What does I mean by? It don't let the cancer to happen. But if you inhibit these genes like RB gene and P53 gene, now these cervical epithelial cells, they will be converted into a cancer because of abnormal division. So these are some important points. Now after seeing this, let's see a few more important points about the human papillomavirus. What are they? Just now we have seen that this human papillomavirus is associated with a premalignant condition, that is cervical intraepithelial neoplasia, and the same human papillomavirus can cause cervical cancer. But please keep these points in mind. Human papillomavirus is also associated with the benign conditions like formation of verrucous warts or human papillomavirus 6 and 11. I have said you, human papillomavirus 6 and 11, they will cause condyloma acuminata or genital warts. They are associated with the giant condyloma, intraepithelial condyloma, not that important, but these are important. So what are the pre-malignant conditions which are caused by HPV? See, cervical intraepithelial neoplasia caused by HPV. We have seen but not only cervical intraepithelial neoplasia, but vaginal intraepithelial neoplasia, vulvar intraepithelial neoplasia, anal intraepithelial neoplasia, and penile intraepithelial neoplasias. All these intraepithelial neoplasias, pre-malignant conditions, all of them are also caused by the HPV virus. Okay. Now, malignant conditions. Like we have seen that cervical cancer is a malignant condition. It is caused by human papillomavirus, but not only squamous and adenocarcinoma of cervix. Carcinoma is a cancer. It's a true cancer. Invasive. See, invasion means breach in the basement membrane. Now, these cells can invade the surrounding structure. So, invasive squamous and adenocarcinoma of cervix, we have seen. But invasive squamous carcinoma of vagina, invasive cancer of vulva, invasive cancer of anus, and invasive cancer of the penis, all these can be caused by the human papillomavirus, which is a very dangerous virus. Okay, so as of now, let's confine to our cervical cancer. Okay, let's continue. See, these are the coilocytes. What exactly are the coilocytes, guys? Coilocytes are the dysplastic cells where the nucleic cytoplasmic ratio increases, and you can see a perinuclear halo. Okay, this is the nucleus which I am showing you right now. This is the nucleus, and you can see a perinuclear halo surrounding. Guys, see, this is how a normal cervical epithelial cell should look like. That's a normal. But here you can see now the epithelial cells are becoming something like this with a very big nucleus. Okay, the cytoplasm was totally sent to the periphery. So these kind of cells are known as coilocytes, which are seen in the cervical intraepithelial neoplasia as well as with the cervical cancer. Okay, now see here the cervical intraepithelial neoplasia. You can see here all these coilocytes are dysplastic cells which are present in the epithelial lining. Okay, well and good. But here in CIN1, the coilocytes, they are more localized to the lower 1/3. Okay, now let's see if there is CIN1, CIN2, CIN3. What is the fate? Guys, from this slide, what I want you to know is this cervical intraepithelial neoplasia 1. See, it is a pre-malignant condition. So, what are the chances of this CIN1 for getting converted into a cancer? That is progression to cancer. Progression of CIN to cancer. How much chances? Usually very, very less. Okay, why? Because CIN1 is a very mild dysplasia. CIN1 is a low-grade squamous intraepithelial lesion. So, the chances are very, very less. But see, CIN3 is a more dysplastic changes will be seen here in CIN3. So it is having more chances for getting converted into a cancer, almost 20%, and you can have a chances up to 40% chances of CIN3 getting converted into cancer. Okay, well and good. Now let's continue our topic with the cervical intraepithelial neoplasia. Guys, please remember what and all we are talking right now is with the cervical intraepithelial neoplasia. So what is the most common age group affected? We have already seen that cervical intraepithelial neoplasia 20 to 35 years, but cervical cancer bimodal distribution. Okay, so what is the screening test done for cervical intraepithelial neoplasia as well as with the cervical cancer? It's one thing, that is the pap smear. Okay, pap smear is a screening test. It's not a diagnostic test, it's a screening test which have almost 42 to 62% sensitivity. Okay, so why we are doing this test? Simple. See, we are doing this pap smear test to prevent the conversion of the CIN to cervical cancer. What does I mean by? See, there is a female. Now she is at 25 years of age. Simple. Let me give you an explanation so that the concept will become clear. See, there is a female who is of 25 years of age. I have done this pap test in her. See, if I have done this pap test, I have seen abnormal dysplastic epithelial cells on the slide. Now I can recommend her certain treatments which will prevent this dysplastic changes getting converted into cancer. So this is the reason why we will do screening test. Pap test is a screening test done to prevent the conversions of the pre-malignant condition into a malignant condition. Why? Because I can prevent it. Now, what exactly is this pap test, guys? In a simple word, it's a cytological study. We are going to collect some epithelial cells from the cervix and we are going to put it on the slide and we are examining under the microscope whether the cells are normal or whether the cells have undergone certain dysplastic changes. Okay, so that's what we are doing in the pap smear. See, for collecting these cells, guys, for collecting the cervical epithelial cells, we are using instrument known as Ayer spatula. Okay, with the help of this Ayer spatula, I am collecting, see, I am going to, for example, this is the cervix, this is the Ayer spatula. I am going to put this Ayer spatula onto the external cervical os and I am going to collect the epithelial cells. Okay, especially from I want the epithelial cells from the transformation zone. I am collecting the epithelial cells from the transformation zone and these epithelial cells are going to be placed on a slide. First of all, they will be fixated and they will be placed on a slide and I am going to examine this cell. So, pap smear is a cytological study. Now, what's the time for pap smear? See, regardless of the age of intercourse, regardless, it doesn't matter when she have participated in the intercourse. It is advised that all females from 21 years of age should take this pap test. If they have any dysplastic changes, we will know that there is some dysplastic change and we can prevent that this dysplastic changes from getting converted into cancer. So, what is the time for pap smear? Regardless of the age of first intercourse, every female is advised to take this pap test from 21 years of age. And what is the best time for pap? Okay, in a normal, normal cycles, what is the best time? It's a pre-ovulatory phase or post-ovulatory phase or during menstrual phase? Which phase? See, at any time you can do the pap, but the best time is a pre-ovulatory phase. Okay, pre-ovulatory phase is the best time for collecting this epithelial cells. Okay, using a Ayer's spatula. So, what are the instruments used, guys? We have already seen that Ayer's spatula can be used, or you can use endocervical brush or cyto brush, which is also known as a cyto broom. Okay, see, you can see here that you can use instruments like a cyto brush or cyto broom for getting these epithelial cells. Guys, important point is why we are using this cyto brush. See, especially cyto brush is used for a liquid based cytology. Okay, liquid based cytology why we are using liquid based cytology, guys? We are using liquid based cytology to increase the sensitivity. Okay, usually what is the sensitivity of the pap test? The sensitivity of the pap test is just a 47 to 62%. Now, if you use this cyto brush and liquid based study, okay, if you are conducting a liquid based study, you can increase the sensitivity of the test up to 90%. If you are just doing a normal pap test using Ayer's spatula and putting under the slide and if you are like watching, then the sensitivity is less. But if you use this kind of a cyto brush or cyto broom and if you are doing a liquid based cytological study, then the sensitivity can be increased up to 90%. That's what I want to put into your mind. So, what is the fixate you use? This is the important MCQ that will be coming in your exam. That's the 95% ethyl alcohol. So, the moment you take the epithelial cells from the cervix, you are going to put it into a fixative. So, the fixate you use for the pap test is 95% ethyl alcohol. Okay. Now, so we are going to prepare 2 slides. Okay. And we are going to examine. So, in the pap test, we are going to prepare 2 slides and we are going to put it under the microscope and we are checking for any dysplastic changes present or not. Okay, well and good. Now, what are the FIGO guidelines for the pap smear? Guys, we have already said that regardless of the age of first intercourse, every female should take this pap test from 21 years itself. Now, from 21 to 29 years, this period, 21 to 29 years, for every 3 years, she should take this pap test. Once in every 3 years, she should take this pap test. Okay, well and good. Now, from 30 to 65 years of age. Now, in this time period, she can take, just like she can take a normal pap test once in every 3 years. There is one more choice. Either she can take this pap test. Now, the other choice is known as a co-test. What is this co-test, guys? In this co-test, in the name itself it is there, co-test, combination test, two tests together. You are taking a pap test as well as you are checking the presence of HPV DNA. What does I mean by co-test? It's a combination test which includes pap as well as HPV DNA. See, if you are taking a pap smear means you should have this once in every 3 years. But if you are going for this co-test means you can take once in every 5 years. Okay, if it's getting negative, once in every 5 years. Okay, that's well and good. Now, after 65 years, there is no need of pap. Okay, no pap smear is indicated if the last 3 pap smears are negative. In the last 10 years, 10 years means you can have 3 paps or you can have 2 co-tests. Am I right? Like in the last 10 years you can have 3 paps or you can have 2 co-tests. Why? Because co-test is done once in every 5 years. Now, if a woman is more than 65 years, there is no need of any further smear if her last 3 pap smears are negative or her last 2 co-tests are negative. Okay, but what if any of the last 3 paps is coming a positive, or I can say in the pap test I can see some dysplastic cells? I should continue the screening for 75 years. Screening should be continued for 75 years. If there is any dysplastic changes in the last 3 paps, in any of the last 3 paps, if you are seeing any dysplastic changes or in co-test, okay, if there is some problem with the co-test, if you find the HPV DNA in co-test, then also you should extend the screening for the 75 years, up to 75 years. This is what I want to put into your mind. So at the end of the day, what I want to conclude here is 21 to 29 years pap once in 3 years. Next, 30 to 65 years, this time period, either you can take the pap once in every 3 years or you can go with the co-test, which includes pap as well as HPV DNA once in every 5 years. Now, more than 65 years, no need of pap if the past 3 paps are negative or the past 2 co-tests are negative. But important point I want you to know here is in HIV positive patients, you need to do yearly screening. Okay, yearly pap tests are indicated if the patient is HIV positive. Okay, now there is one more a funny condition. For example, please concentrate that there is a woman of 35 years. Okay, there is a woman of 35 years. If she is at 35 years, either I can do pap smear or either I can do a co-test. Now I am going with the co-test. Okay. So co-test include what, guys? Co-test include both a pap as well as HPV DNA. Okay, I am just checking both a pap as well as the HPV DNA. Now pap smear is coming something normal. Okay, pap smear. In pap smear there are no dysplastic cells, but HPV DNA is coming a positive. Okay, it's showing that there is HPV DNA in the epithelial cells of the cervix, and pap smear is saying me that there are no dysplastic changes. Okay, well and good. Now what I should do? There is a discrepancy between the pap test as well as the HPV DNA. One is showing the HPV DNA that there is something problem with the epithelial cells, but the cytological study pap is not showing anything. All the cells are normal. What I should do? Repeat the co-testing. Repeat co-testing. Okay, after 1 year. Okay, usually co-testing should be done once in every 5 years. But when you have these kind of discrepancies, like pap is showing something totally different and the HPV DNA is something totally different. Now you can do the co-test after 1 year, and after 1 year, if you are still seeing this kind of discrepancy, or if you are still seeing this kind of HPV DNA in the cells, okay, HPV DNA is coming positive, then you can go for the colposcopy. Okay, repeat after 1 year. If you still find this HPV DNA, then you can go with the colposcopy. Don't worry, we will discuss colposcopy in detail in the later part. Okay. So these are some important points, guys. These are the FIGO guidelines for the pap smear. Okay, now see, I have done the pap smear. Okay, now what if the pap smear result is abnormal? I have done the pap smear, and in the pap smear I can see some abnormalities. What exactly is a pap smear? It's a cytological study. What does I mean by abnormal? Abnormal means I'm seeing that there are certain dysplastic cells which are present. So now what I should do now? I should go with the biopsy. Okay, I should go with the biopsy. Based on a pap smear, I shouldn't do the treatment. Why? Because pap smear is a screening test. I should go with the biopsy, which is more confirmatory. So now, if I can see a lesion, okay, directly, if I can see a lesion on the cervix, directly take the punch biopsy, taken part of the biopsy. What if the lesion is not visible? Now, if I can see a lesion in a resource rich area, what does I mean by resource rich area? In an urban population, in an urban area, in a city. See, I can go with the colposcopy. What does it mean by colposcopy? Colposcopy means it's a magnification device. Okay, I am going to magnify the cervix and I will take a biopsy from that area where there are dysplastic cells. We will discuss colposcopy in detail, don't worry. Now, what if the lesion is not visible and I am there in a resource poor area? See, in a resource poor area means in a rural population. A rural population or in a rural area, in a rural setting. See, if I can't see a lesion, then I will do via or villi. What exactly are this via and villi? Via and villi are visual inspection studies. Via means visual inspection under acetic acid, and villi means visual inspection under Lugol's iodine. Okay, so don't worry, I will make the concept clear. See, I have done the pap smear. General routine examination in a normal 22-year-old, a 25-year-old, a 28-year-old, doesn't matter. She came for a normal examination, routine screening. I asked her, now you should have to take a pap. Why? Because this is it's a FIGO indication that usually a female of 21 to 29 years, you should regularly take a pap once in 3 years. I have asked her, recently have you taken the pap in the last 3 years? She said no. Now I asked her, better take a pap. Now she is taking the pap. Now after doing this pap, I am seeing some abnormal cells. Now I will say her, there are some dysplastic cells in your cervix. It's better to take a biopsy. Now she said, okay, she gave a consent, okay, you can take. Now, if the lesion is visible, what I will do? I will take, see, in this condition, I can see a lesion over here. If the lesion is directly visible to the naked eye, you can take a punch biopsy and you can examine. What if the lesion is not visible? If the lesion is not visible, what you should do? You have to find out the dysplastic cells. To find out the dysplastic cells, you are using a magnification device known as a colposcope. So with a colposcope, you are magnifying the cervix to almost 30 times. After magnification, you are going to put some chemicals, or you are going to use, I will directly say, you are going to put acetic acid onto the cervix. See, usually dysplastic cells appears white. See, this is cervix. I am keeping some acetic acid over here. Now I am magnifying. Now if there are any dysplastic cells which are not seen with the naked eye, but with the colposcope, after keeping this acetic acid, I can see the dysplastic cells which are appearing white in color. Now I am going to take a biopsy from there. If a region is not visible, I will be using colposcopy. Now this colposcopy is a very, more of present in the in urban areas, not in the rural areas. It's a very costly machine. Now what I should do in a rural area, I have already said you, I will be doing via and villi. What exactly are this via and villi? Whenever there is no colposcope, you should identify the dysplastic cells with your naked eye. How is this possible? How means, see, this is the cervix. Imagine that this is the cervix. Now again I am going to put the acetic acid over here. I have said, upon keeping acetic acid onto the cervix, the dysplastic cells will take aceto-white color. The dysplastic cells are going to convert into a more whitish in color. That is the aceto-white appearance. Or I can use Willi. What does it mean by Willi? Visual inspection under Lugol's iodine. I am going to put Lugol's iodine onto the cervix. Normally, see, in a normal cervical epithelial cell, normally glycogen is present. So, glycogen will take up this Lugol's iodine and appears brown in color. But in a dysplastic cells and neoplastic cells, the glycogen stores are rapidly utilized. So, dysplastic cells are deprived of glycogen. So, they won't take up this Lugol's iodine. So, what I am saying, guys, normal epithelial cells will take up the Lugol's iodine and appears brown or mahogany in color, brownish mahogany in color, normal epithelial cells. But the dysplastic cells, when you put Lugol's iodine onto them, they don't take up this color. So they will more looks yellowish. Don't worry, I will show you the gross images. Okay. So lesion visible, punch biopsy. Lesion not visible in an urban setting, go with the colposcopy. In a rural setting, if the lesion is not visible, you have to do the visual inspection by acetic acid and Lugol's iodine. Now please concentrate here. See what exactly is this via? See, via means visual inspection of the cervix with a 5% acetic acid. So if you put this 5% acetic acid, you can clearly see here this area which is more white in color. So this is the area of dysplastic cells. So what I am going to do, I am going to take a biopsy from this area. See, what is Willi? Willi means visual inspection under Lugol's iodine. Normal cells appear brown or mahogany in color, but the dysplastic cells which are deprived of glycogen, they will appear unstained or yellow in color. See, both of them are from a single female, same female. See, this is the area of dysplastic cells. They are appearing more yellowish in color. Okay, sir. Well and good. Now what to do? See, these are more images. I am just showing you to make the concepts clear. See, this is something normal. This cervix is something normal. See, there are no aceto-white areas here. And the whole cervix is more brownish in color. Okay. But see, this is the condition of low-grade squamous intraepithelial neoplasia, which is LCIL, low-grade squamous intraepithelial lesion, not neoplasia, or CIN1. Okay. See, you can see some aceto-white areas after keeping 5% acetic acid. Okay. But here see, upon keeping the Lugol's iodine, you can see this this yellow colored unstained areas. Normal cervix is looking brownish or mahogany. Well and good. Now, see, this is HCIL, where you are seeing the aceto-white areas. With Lugol's iodine, you can see this yellow color areas. Okay. So, these are all for making the concepts more clear. You can see after putting 5% acetic acid, you can see a aceto-white area here. Okay. You can see a aceto-white area here. All this is the aceto-white appearance because of the dysplastic cells. Okay. Aceto-white areas. Okay. Now, what are the different management strategies with different pap smear results? For example, if the pap smear result is absolutely normal, a 25-year-old female came to my clinic and now she is having a pap smear test. Now, whenever she is having a pap smear test, the result came absolutely normal. There are no dysplastic cells in her cervix. If the result is normal, then continue the pap smear as per the ACOG, according to ACOG guidelines, just continue the pap smear. Or according to a FIGO guideline, just continue the pap smear, just like once in every 3 years. Okay, well and good. Now, what if she is having ascus in her pap smear result? Ascus means, see, there are atypical cells, okay, atypical squamous cells of unknown significance. See, there are some atypical cells are there. See, this is not a CIN1. This is not CIN2. are not CAN3. There are some atypical cells. See, to call it as a CAN1, the dysplastic cells should occupy the lower 1/3, but they are not having this thing. These are atypical cells. We don't know, what is the significance of them. Now, what I should do? If I am having this kind of ascus, repeat the PAP after 6 months, or I can repeat the PAP in the next year. If the report shows still after 1 year or 6 months, okay, I am just doing the follow-up. If still the report shows increased ascus, the number of atypical cells are getting increased, then what I should do? I should do the colposcopic biopsy. Okay, I should do the biopsy now, not just taking the cells. I have to take up a chunk of a tissue and I should do the examination, okay, of that tissue. Now, what if the pap smear result is showing a atypical squamous cells, where atypical squamous cells are there, where the histology, or histopathological examination cannot exclude the H cell. What does I mean by? See, I have done the pap. There are atypical cells. After atypical cells, I have taken a biopsy and I am doing a histopathological examination now. Now I have done the histopathological examination, but still I cannot rule out the H cell, or I cannot rule out a pre-malignant condition. Now what I should do? Now again I have to go for the colposcopy and endocervical curettage. Colposcopy along with the endocervical curettage. See, if I am having atypical cells and I am having atypical cells, now what I have done? I have done the histopathological study. I have examined them, but still I can't rule out this H cell. Then what I should do? I should go with the colposcopy and endocervical curettage. Okay, well and good. Now if I am getting agus, what does I mean by agus? Atypical glandular cells. See, these are glandular cells. Atypical glandular cells of unknown significance. We all know that there are endometrial glands. So, if I am having this kind of agus, this female is at a risk of developing endometrial cancer and cervical cancer. Okay. Now, what I should do now? Now, as she is at a risk of getting endometrial cancer and cervical cancer, now I should do endometrial biopsy. Along with the endometrial biopsy, I should also do colposcopy and endocervical curettage. Okay. So, endometrial biopsy is to rule out the endometrial cancer. Colposcopy and endocervical curettage are to rule out the cervical cancer. Okay. But from here, these are the very, very important points which we are going to discuss right now. If pap smear result is normal, what you should do? Just normal. Repeat the pap smear according to FIGO guidelines. From here, see, if the pap smear result is showing CAN1, for me, pap smear result is showing CAN1. What does I mean by? Dysplastic cells are present in the lower 1/3, okay, of the epithelial lining. Now, what I should do? Now, I shouldn't treat, I have already said, I shouldn't treat a female based on a pap smear. I have to confirm this with a more confirmatory test and with a biopsy. What is that? I have to go with the colposcopy. Okay, see, LCL or CAN1 is of a more mild dysplastic changes. So, either it's up to me. I can do endocervical curettage or plus or minus. But you should do a colposcopy. Guys, listen. Why we will do colposcopy? Colposcope is a magnification instrument for the localization of the dysplastic cells. When we will use colposcope? We will only use colposcope when I can't see a lesion. Then I am taking the assistance of this colposcope. If I can see a lesion, if a lesion is visible, then do the punch biopsy. The same way, H cell. H cell is according to Medvizz classification. In CAN classification, CAN2, CAN3 and carcinoma in situ, all of them are H cell according to Medvizz. Okay, well and good. Now what I should do here? Here also, do colposcopy and endocervical curettage also. Do colposcopy, here it is not like plus or minus. Do colposcopy along with endocervical curettage. But if you can see a lesion, you can directly take a punch biopsy. Okay, something like that. See, why we are doing endocervical curettage? Endocervical curettage, endocervix is the site, most common site for the adenocarcinoma to develop. So that is the reason why we are taking the endocervical curetages also. Okay, I have said, see, the most common site for the CIN or cervical cancer is the transformation zone. That's okay. But if I am talking in specific about adenocarcinoma arises from endocervix. We will discuss when we are discussing the cervical cancer. We haven't gone to the cervical cancer yet. Still we are in the cervical intraepithelial neoplasia and its management strategies. See, LCIL, do colposcope plus or minus endocervical curettage. If the lesion is visible, do the punch biopsy. See, if you are seeing HCIL, high grade squamous intraepithelial lesion, do colposcopy. Along with that, do endocervical curettage. If you can directly say see a lesion, do the punch biopsy. Okay, well and good. Now, these are the special conditions. Something like, you are seeing LCIL, low grade squamous intraepithelial lesion during a pregnancy. She is a pregnant female. Now, in this pregnant female, it's coming LCIL. The pap test is coming LCIL, or I can say CIN1. What I should do? Should I have to do a further investigation here? No investigation should be done till delivery. Okay, you have to wait. Investigations, whatever you want to do, colposcopic biopsy or whatever, do it 6 weeks after the delivery. Okay, you have to wait 6 weeks postpartum and do the further investigation. But during pregnancy, don't try to do any examination. What if there is a HCIL? Okay, LCIL, no investigation. HCIL is more dangerous condition, which includes a CIN3 and carcinoma in situ. Now, in this condition, what you should do? Okay, go with the colposcopic biopsy. Okay, with the colposcope, take a biopsy. If the lesion is visible, do the punch biopsy. That's anyway you are going to do. So, this is the pap smear report, different pap smear reports and different management strategies which you are going to do. Okay, well and good. Now, let's see some important points about the colposcopy. See, I have said this colposcope which you are seeing here is a magnification device. So, it can magnify up to 20 or even sometimes some colposcopes can magnify up to 30 times. Okay. So, what is the use of this colposcope? You are going to magnify the cervix. Before magnifying, you have to put the acetic acid. You have to apply 5% acetic acid onto the cervix. Now you have to magnify. Now when you are magnifying, if there is any dysplastic cells, means if there is any dysplastic area, means that area will appear aceto-white. We have already seen this. See, gold standard, this colposcopy is a gold standard for evaluation of abnormal cervical pathology. Okay, so it's a gold standard for knowing the cytology of the cervix. For abnormal cervical cytology, what is the gold standard, guys? It's the colposcopy. That is the reason why, see, in all these conditions, see, you are doing the colposcopy. Okay, so here also colposcopy. See, to examine the cervical cytology, what is the gold standard? It's the colposcopy. Okay, what is the disadvantage? The main disadvantage of this colposcopy is the upper 2/3 of the endocervix is not visualized. Okay, colposcopy, what it is doing? It is magnifying the cervix. It is magnifying the cervix. How can you see something inside the cervix? You can't see that, right? So, colposcopy cannot document the endocervix. Okay, now let's see what exactly is this cone biopsy. Cone biopsy is done to confirm the findings of colposcopy. What does I mean by? See, what you are doing is you have done the pap test. Initially pap test, it's a screening test. To confirm pap, you are doing a colposcopy, more diagnostic. Now, why we are doing this cone biopsy? Guys, this cone biopsy is done, it's a more confirmatory, something like that. See, there is any discrepancy between pap and colposcopy, then you have to have a more confirmatory test. That's the cone biopsy. What does I mean by? See, pap is saying something abnormal, but colposcopy is saying something normal. Or pap, try to understand something like this. There is a discrepancy. Pap results are not coinciding with the colposcopic results. Then you have to go with the cone biopsy. Or if you are having unsatisfactory colposcopy, Unsatisfactory colposcopy means you are not satisfied, you are not able to see the transformation zone, or you can't localize the dysplastic cells. In such conditions, you have to go with the cone biopsy. What exactly is this cone biopsy? Cone biopsy means removing a cervix, removing lower part of the cervix in the form of a cone. Okay, in the form of a cone, you are taking a chunk of the cervix in the form of a cone. And what you are going to do with that? You are going to do the examination. This is a biopsy. You are getting more part of a tissue, so you will be knowing there is any dysplastic or neoplastic changes. Important is what they will ask you. What are the indications of a cone biopsy when you are going to do a cone biopsy? So these are all the indications. See, suspecting adenocarcinoma. Guys, what is the disadvantage of colposcopy? Colposcopy cannot see, or with the colposcope you cannot see endocervix. From endocervix, I have said, you will be having adenocarcinoma. So if you are suspecting adenocarcinoma, you have to do the cone biopsy. If endocervical curettage is coming positive, see, you have done the colposcopy along with the endocervical curettage. If endocervical curettage is coming positive, what does it mean by endocervix is having the dysplastic changes? It means that there is a chance of adenocarcinoma. So you have to go with the cone biopsy. Why? Because again I am repeating, colposcope cannot visualize the endocervix. Okay. Now, if there is any discrepancy in pap smear result and colposcopy, this we have already seen this. Okay. So pap smear is saying that there is some abnormality or there is dysplastic cells, and colposcopy is saying colposcopic biopsy. I mean, colposcopy is something normal. If there is a discrepancy, for more confirmatory results, do the cone biopsy. If you can't localize the squamocolumnar junction, this is unsatisfactory. Actually, you have to localize the squamocolumnar junction, and that's the place where you have to take a biopsy after putting this acetic acid. Now, if you can't localize the squamocolumnar junction while you are doing colposcopy, go with the cone biopsy. If you are suspecting invasive carcinoma, okay, you are suspecting the cancer, then go with the cone biopsy. Okay, you are suspecting like there is a breach in the basement membrane zone, you should have to have a more chunk of a tissue. Then here you are taking a cone biopsy. Okay, invasive carcinoma is suspected based on colposcopy and cytological studies. Cytological studies is a pap smear. Colposcopy, you have done the biopsy. Now we are suspecting that what if there is a spread of this cancer by what if there is a breach in the basement membrane zone and there is a spread of these dysplastic cells to the surrounding. So in that condition, you can go with the cone biopsy. Okay, so these are the indications. Now, what are the complications of this cone biopsy? Do you think this is good? See, if you are removing some part of the cervix, you can expect a bleeding, and this part can get infection. Remember, so in this part you can expect so much of inflammatory changes, and this part can undergo stenosis. Okay, so cervical stenosis, or please keep this point in your mind, guys. During pregnancy, the cervix should be closed, it should be tight enough. But if you are removing so much stroma of the cervix, it will become loose. So during pregnancy, it can simply dilate. So that can cause cervical incompetence. So what are the complications of this cone biopsy? Bleeding, infection, cervical stenosis, and cervical incompetence. So this cervical incompetence can lead to second trimester abortions. Okay, second trimester recurrent abortions. Okay, why? Because every time in the second trimester, okay, this cervix is getting dilated. Why? Because you have removed some part of the tissue. It's not strong enough to hold the baby, so it's simply dilating. Now, see, this cone biopsy, it's not only a diagnostic. See, first you have done the pap, you have done the colposcopy. For more confirmatory results, you are doing the cone biopsy. See, so cone biopsy is a diagnostic. Okay, well and good. But the same cone biopsy, removing some part of cervix, is also therapeutic in certain conditions. The same cone biopsy is therapeutic for stage 1A1 of cervical cancer. So how you are going to treat Cervical cancer stage 1A1. Again, when we are doing the cervical cancer treatment, we will discuss there. Stage 1A1 of cervical cancer, you can use cone biopsy as a treatment option. Okay, well and good. See, cone biopsy is not a treatment for cervical intraepithelial neoplasia. Don't say something like that. To confirm the results of pap and colposcopy, we are doing the cone biopsy. Okay. Now, so how you are going to manage the cervical intraepithelial neoplasia? The management. See, you can do a prevention of the cervical intraepithelial neoplasia, or you can do the definitive management. First, let's see the preventive measures. Okay, there is no cervical intraepithelial neoplasia. You don't want to have a cervical intraepithelial neoplasia. You have to take a vaccines. So, what are the vaccines available? Bivalent vaccine, quadrivalent vaccine, and 9-valent vaccine, which is the best vaccine. See, what exactly is this bivalent vaccine? See, bivalent vaccine will give protection against 16 and 18. What are the 16 and 18? HPV 16 and HPV 18. Bivalent vaccine gives protection against 16 and 18. The name of the vaccine is Cervarix, and you have to take a 3 shots. 0, 1, 6 months means the day you have taken. After 1 month and after 6 months you have to take the vaccines. 0, 1, 6. 3 shots. Quadrivalent vaccine. Quadrivalent means quadra means 4, or quad means 4. It gives protection against 6 and 11. We all know that 6 and 11 causes condyloma acuminata genital warts. 16 and 18 causes cervical cancer. 16 causes squamous cell carcinoma of cervix. 18 causes adenocarcinoma of the cervix. So what is the vaccine? Vaccine is a Gardasil. Okay. So Gardasil, 3 shots, 0 to 6 months. Okay, 3 shots you have to take on 0. That's first time you are taking. After 2 months, after 6 months you have to take. Now the 9-valent vaccine, it gives protection against the 9 different strains of high risk HPVs. So this also you have to take on 0 to 6 months. Okay, well and good. So in this vaccine, you can use an adjuvant. So adjuvant used in HPV vaccine is MCQs. These are all the MCQs. So what exactly is an adjuvant, guys? Adjuvant is a more immunogenic. It boosts up the vaccine. Okay, it boosts up the effectiveness of the vaccine. So mixing aluminium sulfate in this vaccine makes the vaccine more effective kind of thing. So in a simple way I can say something like that. Okay, so what is the adjuvant used, guys? It's the aluminium sulfate. So what is the ideal age for the vaccine administration? When a boy or a girl should take this? Usually 11 to 12 years is the ideal age, but you can take, the range can be between 9 to 26 years. Can a boy take HPV vaccine? Because a boy is not having a cervical, cervix, so he cannot have cervical intraepithelial neoplasia, cervical cancer. Should a boy take HPV vaccines? Yes. Why not? Because HPV is associated with the genital warts, both in male and female. And I also have said HPV is associated with many malignant and pre-malignant conditions. HPV is associated with the cervical intraepithelial neoplasia of anus. So HPV is associated with the cervical intraepithelial neoplasia of penis. Even boys can get affected with the HPV. That's so damn true. Okay. Now, so what is the most common complication? See, after taking vaccine, not only HPV vaccine, any vaccine, the most common complication is a fainting or syncope in the adolescents. Okay. So among adolescents, after taking a vaccine, the most common complication you can expect is a fainting or syncope, sudden loss of consciousness. Okay, well and good, sir. So I have taken a vaccine. Should I have to continue my screening? Okay, so I got my vaccination done, when I am 15 years of age. Now should I have to have pap smear, regular testing every once in 3 years? Absolutely yes. Screening should be continued even after vaccination. That's very, very important. Okay, vaccination, doesn't matter if she have taken the vaccination or not. From 21 years, every 3 years, she should have to take the pap test. Okay, well and good. So what are the definitive treatments? Preventive measures we have seen. They are the vaccines. Definitive measures include lots and lots of surgeries as well as the ablative methods. What are they? Ablative methods include cryosurgery or laser ablation. Cryosurgery means by using the cool gases, we are going to destroy the dysplastic cells. So ablative methods include cryosurgery, laser ablation. Or surgical procedures include loop excision of transformation zone. We are taking out the transformation zone. Okay, large loop excision of the transformation zone, which is known as LETs, or LEAP, which is a very important surgery for the exams. Loop electro-excisional procedures. Okay, LEAP, not loop, I am saying loop, sorry, it's a LEAP. Okay, loop electro-excisional procedures can be done, or you can do conization, or you can do the hysterectomy. Guys, what I am trying to say, see, there are preventive measures, vaccines, or we can have a definitive treatments for the CAN. Now you can ask me, so we are having so many definitive treatments. For example, if I am having CAN1, what kind of definitive treatment you are going to give to me? If I am having CAN2, what we should do? If a patient is having CAN3, what we can do? See, that we will be discussing in this slide. Okay, so please concentrate. That's usually CAN1, for the conversion of CAN1 into CAN3, this is not a treatment, just in general I am saying. CAN1, it takes almost 5 years of time for getting converted to CAN3. And if you are having CAN3 right now, it might take almost 10 years for getting converted into cervical cancer. See, not all CAN3 will be converted into cervical cancer. Only almost a 20 to 30% chance, or maximum 40% chance is there that CAN3 will be converted into cervical cancer. But not all CAN3 will be converted into cervical cancer. If at all it's converting, it takes almost 10 years. Okay, well and good. See, usually CAN1, if a female is having CAN1, how I have to treat her? See, do observational yearly HPV. Every year, just do the follow-up. Okay, yearly HPV, do it, and yearly PAP test you can do it. Okay, yearly PAP or yearly HPV you can do it. Simple follow-up. For CAN1, not much, just follow-up. Okay, every 6 to 12 months or every yearly you can do it. Not much. Why? Because CAN1 most of the time normally regresses within 2 years. Even if you don't treat any, even if you don't treat, it will simply regress by itself within 2 years. Now, what if CAN1 is not getting regressed? You are doing the follow-up for the next 2 years, still it is showing CAN1. What you have to do? You have to go with the ablative methods. You have to go with the ablative methods like laser ablation or cryotherapy. This is very important. Okay, so persisting CAN1, if the CAN persists more than 2 years, what's the management? What's the definitive treatment? It's the cryotherapy or cryosurgery. Okay, well and good. So if a female is having CAN2, CAN3, how we are going to manage? What is the definitive treatment? It is a LEAP, loop electrosurgical excision procedure. LEAP should be done for both CAN2 and CAN3. Now, what if there is a recurring CAN3? Okay, you have done, but again, when you are doing follow-up, again you are seeing the CAN3 dysplastic changes. Then what you have to do? Do the hysterectomy. Okay, so for recurring CAN3, you can go with the hysterectomy. And now, the laser ablation. Okay, the ablative procedures. Laser ablation is best if CAN, cervical intraepithelial neoplasia, is extending to the vaginal fornices. If the CAN, if you are getting a report that vaginal fornices are being, vaginal fornices are being affected with this cervical intraepithelial cells, or if you are seeing these dysplastic changes in the vaginal fornices, then you have to go with the laser ablation. Very simple. CAN1, simply follow up. If the CAN1 is persisting more than 2 years, do the cryosurgery. For CAN2, CAN3, what you have to do, guys? You have to do the LEAP. For recurring CAN3, hysterectomy. And if you are seeing that this CAN is extending to the vaginal fornices, then the best would be laser ablation. Okay, guys. Now here you can see, this is a cervix which have this white areas indicating that there is CIN, cervical intraepithelial neoplasia, and in this condition it is CAN3. And upon putting this Lugol's iodine, you can see this yellow color area. Okay, these are the cervix of two same patients. Okay, so this is also CIN3. Okay, I'm saying, okay, you can't know whether it's CIN1 or CIN2 just by looking just like that. I'm saying this is CIN3. So for CIN3, what is the treatment option, guys? The treatment option is loop electrosurgical excision procedure. So that's being done over here. Okay, so this is after the surgery. We have removed, okay, like by electrosurgically we have done the excision of that part of cervix which have the dysplastic cells. So this is after the surgery. Okay, after the surgery, I have kept the that acetic acid, not in the sense here, acetic acid is kept over here. But can you see the dysplastic cells over here? There are no dysplastic cells. Okay, everything is getting normal over here. Even after keeping that Lugol's iodine, see everything, all the cervical area is looking brownish in color. It means the dysplastic cells have gone. Everything become normal. So CIN2, CIN3, it is the leap. Now, see what you can see here is this is the electrosurgical loop. Okay, you are trying to remove this part of cervix which have the dysplastic cells. Okay, for getting a more clear idea, I just want you to look at this video where the loop electrosurgical excision procedure is happening. See, the surgeon is removing that part of a cervix which have the dysplastic cells. Okay, please concentrate. Okay, that part was removed which is having the dysplastic cells. Now he is coagulating the edges. Okay guys, so far we have discussed the cervical intraepithelial neoplasia and its treatment managements. Okay, so in the next video we will be discussing in detail about the cervical cancer. Hope the lecture is helpful. Thank you.